This is the beginning of a new series where I will be teaching you every single systemic pathologies one by one, starting off with respiratory pathology. Throughout this video or upcoming videos, everything that I'm gonna say, all the pictures, almost all of them that I'm gonna use are going to be either from Robbins or Horsemohan. And let me ensure you, for the topics that I have taught, you will be able to answer all Viva questions and all university exam questions without failure. But all you have to do, all you gotta do is trust me, trust the process, and make a note of everything that I put in this video. Alright, so let's begin. The respiratory pathology. Before studying about any systemic pathology, you need to know the basic anatomy of that system. And keeping in mind that you know nothing about respiratory system, first I'm going to teach you the basic anatomy of respiratory system and then we'll get into the pathologies. So basic anatomy of respiratory system. First, the respiratory tree. So there's your trachea. The trachea, it bifurcates at the point of carina into primary bronchus, the left and right primary bronchus. They enter the individual lungs, the left and right lung, where the primary bronchus, they divide into secondary bronchus. Then the secondary bronchus, they divide into tertiary bronchus. And this marks the end of the bronchus. Alright, so there was your trachea, which bifurcated into primary bronchus, the left and right primary bronchus, which entered the left and right lung. Inside the lung, the left and right primary bronchus, they further divided into secondary bronchus. The secondary bronchus further divided into tertiary bronchus. After bronchus, you have multiple generations of bronchioles. Finally reaching the terminal bronchiole. Now, terminal bronchiole is significant, and here's why. The part of the respiratory tract, I repeat, the part of the respiratory tract after terminal bronchiole is acinus. And acinus includes three things. Number one, the respiratory bronchiole. Number two, the alveolar duct. And number three, the alveolar sac. Again, I repeat, acinus includes three things: the respiratory bronchiole, the alveolar duct, and the alveolar sac, or simply RDS. Alright, so there was trachea, which bifurcated into primary bronchus, which further divided into secondary bronchus, which further divided into tertiary bronchus, which then gave multiple generations of bronchioles, finally leading up to terminal bronchiole. The part of the respiratory tract after terminal bronchiole is called acinus, which includes the respiratory bronchiole, the alveolar ducts, and the alveolar sac. Now the histology. Starting off with the histology of trachea. It has mucosa, submucosa, cartilage plus muscle, and adventitia. Mucosa has epithelial mucosa and lamina propria. The epithelial mucosa contains which epithelium? It contains the respiratory epithelium, which is nothing but the ciliated pseudostratified columnar epithelium. What is the significance? It has two important things. Number one, goblet cells. Goblet cells, they produce mucus. And number two, cilia. Cilia, they beat or row, they beat uniformly in rowing fashion. The submucosa, it contains the submucosal glands, which are serous and mucous glands. Then you have the histology of bronchus, which also has mucosa, submucosa, cartilage, and adventitia. Mucosa contains the epithelial mucosa, which is again made up of respiratory epithelium or ciliated pseudostratified columnar epithelium, lamina propria, as well as muscularis mucosa. It has an extra layer of muscle inside of it, made up of smooth muscle. The significance of which is that during asthma, there is hypertrophy of this muscular layer. As a result, there is thickening of the muscular layer, muscular layer, constriction of the lumen, narrowing of the lumen, and difficulty breathing. The submucosa contains the submucosal glands. These are the submucosal glands. Lung. So if you look at the lung parenchyma, you will see lots and lots of air-filled spaces, and these are your alveoli. Alveoli, they are lined by two types of epithelium, the two types of cells, type 1 pneumocyte and a type 2 pneumocyte. Again, type 1 pneumocyte and type 2 pneumocyte. Type 1 pneumocyte is flat and it allows for the exchange of gas. Type 2 pneumocyte, on the other hand, is cuboidal, granular, and it has two major functions. Number one, it is stem cell, that is, it gives rise to other pneumocytes. And number two, it produces surfactant, which reduces surface tension. All right. Communications within acinus. So there are three types of communications present within acinus. One alveoli communicates with another alveoli with the help of a pore present in between them. This is called the pore of Kohn. One bronchiole communicates with another bronchiole with the help of a channel connecting them. This is called the channel of Martin. One bronchiole communicates with an alveoli with the help of a channel as well. This is called the channel of Lambert. So there are three. AAP, alveoli communicates with alveoli with the help of pore of Kohn. BBM, one bronchiole communicating with another bronchiole with the help of channel of Martin. And BAL, the bronchiole communicates with alveoli with the help of channel of Lambert. So with that, we are done with basic anatomy. Now the pathologies. Under respiratory pathology, we are going to look at the obstructive pulmonary disease, the restrictive pulmonary disease, the pulmonary infection, and finally the bronchogenic carcinoma. Starting off with obstructive pulmonary disease. Under obstructive pulmonary disease, we have four major diseases: chronic obstructive pulmonary disease, asthma, bronchiectasis, and bronchiolitis. Under chronic obstructive pulmonary disease, we have emphysema and chronic bronchitis. Both of them have strong, or shall I say very strong, association with smoking. Starting off with emphysema. Emphysema. Number one, definition. Emphysema is permanent damage to acini. See, so the emphysema is the pathology of acini. Acini. What is acini? The part of the respiratory tract. The part of the respiratory tract after a terminal bronchiole is acini. It includes the respiratory bronchiole, the alveolar duct, and the alveolar sac, or RDS. All right. Permanent damage. What does it mean? Remember the three words, the three terms. All right. So there is destruction of acinus. There is dilation of acinus, and there is fusion of acinus. Remember these three terms: destruction, dilation, fusion. Destruction, dilation, fusion. Destruction, dilation, fusion. All right. Etiology. The most common etiology for any chronic obstructive pulmonary disease, be it emphysema or chronic bronchitis, is smoking. It's smoking. The other are environmental pollution, occupation, genetics, occupation like occupation acquired diseases like pneumoconiosis and stuff. And the specific cause for emphysema is also alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Okay. Now pathogenesis. The pathogenesis is described by protease antiprotease hypothesis. Before getting into the hypothesis, here's what you need to know. The alveoli present inside your lung is just like a rubber band. What do I mean? So when you pull a rubber band, it stretches, and then you leave it, it recoils back to its original configuration. Why? Because it possesses the property of elasticity. And what is elasticity? It is the ability of a substance, an elastic substance, to regain its conformation as soon as the deforming force which was initially being applied is removed. इतना तो physics आता है ना, right? You know this much physics. Deforming force is removed. Due to elastic property, the elastic substance, it comes back to its original position, original configuration. Just like this rubber band, you have your alveoli. Inside alveoli, there is filling up of gas. As a result, the stretching of the wall of the alveoli takes place, and the alveoli, it dilates. After maximum stretch, it recoils back to its original configuration. Now, this elastic property, like that of a rubber band, is present in alveoli due to the presence of a specific protein fiber, and that is elastic fiber. Okay. Now, let's get into the hypothesis. See, there are two types of proteins circulating in your blood. Number one, protein that breaks down elastic fiber, or elastase, and protein that prevents the breakdown of this elastic fiber, or anti-elastase. Fine? Elastase, anti-elastase. Since elastase is breaking down elastic protein, it is protease. Since anti-elastase is preventing the breakdown of this protein, it is anti-protease. So you have elastase and anti-elastase, which are nothing but protease and anti-protease. Physiologically, that is normally the amount of elastase and the amount of anti-elastase, or the amount of protease and the amount of anti-protease circulating in your blood is the same. That is why there is no excess destruction of elastic fiber. Elastase is something that is produced by neutrophil. And talking about anti-elastase or anti-protease, the most famous anti-protease present in your body, in your blood circulation, is produced by your liver, and it is alpha-1 antitrypsin. So I mentioned various etiological factors here, right? What do? They either increase the amount of elastase or decrease the amount of anti-elastase, or do both. That is, increase elastase and decrease anti-elastase at the same time. As a result, elastase becomes more than anti-elastase, there is more destruction of elastic tissue, and there is emphysema. Got it? No? Okay. Hear me out. This simple, very simple. There is elastase that breaks down elastic tissue. There is anti-elastase that prevents the breakdown of elastic tissue. When elastase is more than anti-elastase, there is excess breakdown of elastic tissue. When there is excess breakdown of elastic tissue, the alveoli, it loses its ability to recoil, and the person gets emphysema. Boss, that much. See, elastase, anti-elastase normally in your body equal. In emphysema, elastase more or anti-elastase less, or there is elastase more and anti-elastase less. Overall, elastase more than anti-elastase. As a result, there is excess breakdown of elastic fibers. The alveoli loses its ability to recoil, and the person gets emphysema. Good. All right. So this is your basic pathology, pathogenesis. Now, specific pathogenesis for two etiological factors. The most common etiology, that is smoking, and the specific etiology, that is alpha-1 antitrypsin deficiency. First, smoking. See, smoking does both. It increases elastase. It also decreases anti-elastase, right? It decreases anti-elastase, it also increases elastase. How? So smoking, it applies stress in acinus, resulting in inflammation, and due to inflammation, there is recruitment of inflammatory cells, which also includes obviously the neutrophil. And it is said that smoking results in 10 times increase in the number of neutrophil. And if I remember correctly, previously I said that it is the neutrophil that produces elastase. That means 10 times the number of neutrophil, 10 times the amount of elastase. So there is immense increase in elastase. Second, the smoke produced contains oxidant, which inhibits the activity of alpha-1 antitrypsin. So there is reduced activity of anti-elastase. So there was increase in elastase. Now there is also reduced activity of anti-elastase, overall leading to increased fibrolytic destruction of elastic fibers, resulting in emphysema. Next, genetic reason or alpha-1 antitrypsin deficiency. See, it's your liver that produces alpha-1 antitrypsin. What is it? It is an anti-protease. So you can also call it alpha-1 protease inhibitor because it is acting against protease now. It is inhibiting the activity of protease. So it is alpha-1 and protease inhibitor, right? So which gene would be responsible for the production or the synthesis of this protein or the production of protease inhibitor protein? Obviously protease inhibitor gene. Protease inhibitor gene. Now the question arises, in which chromosome is the protease inhibitor gene present? It is present in chromosome number 14, 14. So this is chromosome number 14 with protease inhibitor gene, more specifically SERPINA1. Simple, SER simply stands for serine, P for protease and IN for inhibitor. So serine protease inhibitor type A1. That's not important. What is important for you to know is that the gene that is responsible for the production of alpha-1 antitrypsin or alpha-1 protease inhibitor, it's present in chromosome number 14. And this gene has two allelic form. There's the M form and the Z form. The M is normal. If you combine two N together, let's say normal, N, two N together, you get an M. So it's the normal allele. Then if you spell diseased or say diseased with a Z, diseased, right? So Z is the diseased allele. So this allele, they are obviously present in pair. Let's look at the various genotypes formed by the allelic pairs. So there's protease inhibitor MM. This is the normal genotype which produces a normal alpha-1 antitrypsin. Then there is protease inhibitor MZ. So it is partially normal and partially diseased or a carrier genotype. Then there is protease inhibitor ZZ. That is, this is a diseased genotype. See, another question that arises is that in emphysema, which two organs are affected? Okay, the lung is affected because you have emphysema. It is a lung pathology. But if the emphysema is due to alpha-1 antitrypsin deficiency, then your liver is also affected. How? See, when you have diseased allelic pair, right? Protease inhibitor ZZ, which is diseased genotype. Diseased genotype. What happens? What happens if there is diseased genotype? There is production of misfolded alpha-1 antitrypsin in the liver. And the accumulation of misfolded alpha-1 antitrypsin in the liver causes liver cirrhosis. Alright, now the types of emphysema: centri-acinar, pan-acinar, distal acinar, irregular. Very easy, hear me out. See, this is your respiratory bronchial, this is your alveolar duct and sac. Alright, respiratory bronchial, alveolar duct and sac. 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 In centri-acinar, which part is affected? Central part is affected. Which is the central part? The respiratory bronchial is the central part. So it's the respiratory bronchial which is affected. The alveolar duct and sac are spared. Pan-acinar. Pan means what? Complete. That means the complete acinus is affected. Respiratory bronchial as well as alveolar duct and sac are affected. Distal acinar. That means the distal part of the acinus is affected. That is the alveolar duct and sac are affected. Respiratory bronchial is spared. Irregular emphysema. That is, there is irregular involvement. Somewhere respiratory duct and sac are affected, somewhere somewhere alveolar duct and sac are involved, somewhere respiratory bronchial is involved. Which is most common clinically? That is, a patient approaches you with signs and symptoms of emphysema. Then which type of emphysema is most commonly seen? It is the centri-acinar emphysema. So most common clinically is centri-acinar type. Which is most common histologically? That is, let's say a person has died and you do autopsy of this person, and if the dead body seems to have emphysema in its lung, then the type of emphysema seen histologically upon autopsy is irregular emphysema. Centri-acinar emphysema is caused due to smoking. Smoke goes up, so the most common lobe affected is upper lobe. Pan-acinar is due to alpha-1 antitrypsin deficiency. Since upper lobe is already affected, it's the lower lobe that gets affected. Imagine the distal part of the acinus, the alveolar duct and the alveolar sac, as a balloon filled with air. Now let's say this balloon bursts, pops spontaneously. As a result, all the air from inside the balloon leaks out. As a result, the chest gets filled with air, which is pneumothorax. Since there is spontaneously bursting of the balloon, it is spontaneous pneumothorax. So spontaneous pneumothorax is seen where? Where there is distal balloon. Distal balloon means the distal part of the acinus is involved. That is distal acinar or paraseptal emphysema. Alright, one last revision. So centri-acinar, the central part of the respiratory bronchiole is affected, the duct and sac are spared. Pan-acinar, the complete acinar, that is respiratory bronchiole, alveolar duct and sac are affected. Distal acinar, that is the distal part of the acinus or the alveolar duct and sac are affected, the respiratory bronchiole is spared. Irregular, there is irregular involvement. Somewhere it's the respiratory bronchiole that is affected, somewhere it is the alveolar duct and sac that is affected. Most common clinically, centri-acinar. Most common histologically, irregular. Smoking causes centri-acinar, affecting the upper lobe. Alpha-1 antitrypsin deficiency causes pan-acinar, affecting the lower lobe. Spontaneous pneumothorax is seen associated with distal acinar. Alright, so in centri-acinar, there is partial involvement and partial normal. So grossly as well, you can see partial involvement, and areas that is normal, Pan-acinar, there is complete involvement. So grossly as well, you will see complete involvement. In distal acinar or paraseptal, it's the septal region that is affected. Okay, I hope you can determine the type on the basis of these gross features. So there is partial involvement here, right? But then these areas, they are normal. These areas, they are normal. These areas, they are normal. That means there is partial involvement, centri-acinar. The complete parenchyma is emphysematous. Complete parenchyma. So it is pan-acinar. It is only the paraseptal region, the septal region that is affected. So it is paraseptal emphysema. What is this? This is also emphysema, but it is associated with the formation of bulla and blebs, so-called bullous emphysema. Microscopy. At the beginning of emphysema, during the definition of emphysema, I asked you to remember 3 words, right? These 3 words are important in microscopy. See, what did I say? Emphysema, there is damage to acini, which is associated with 3 stuff. Number 1, destruction. Due to destruction, you can see floating septa. So you have alveoli, in between alveoli there are septa, and these septa, they break down and then float. So floating septa due to destruction. Number 2, dilation. Due to dilation, the alveoli, they become larger in size. Number 3, fusion. Due to fusion, there is increased pore of Cohen. Clinical feature. See, there was destruction of elastic tissue. As a result, the alveoli lost its ability to recoil. So the patient is able to take in oxygen but unable to flush out carbon dioxide. So what happens? 2 things happen. Number 1, the patient gets a barrel-shaped chest. Why? Enough air is being taken in, enough air is being inhaled, the lung is filled with air, but the person is not being able to exhale air out. Enough is being inhaled, so the lung, it grows larger in size due to overinflation. So the person has overinflated large lung. The diaphragm gets flattened as it gets pushed down. So overinflated large lung with flattened diaphragm. Second, pink puffer. See, normally during chronic obstructive pulmonary disease, Due to obstruction, what would you expect? Due to obstruction, reduced oxygen in blood, leading to hypoxia, eventually leading to cyanosis. But in early emphysema, as I said earlier, the person is able to take in oxygen easily, but not being able to flush out carbon dioxide. That means the amount of oxygen in the blood is okay. The oxygen is well saturated with oxygen. The blood is well saturated with oxygen. So pink. Puffer, why? Again, the person is having dyspnea, unable to breathe properly, unable to flush out carbon dioxide, dyspnea. So as compensation, he or she starts pursed lip breathing. That is inhalation with closed lip and exhalation with pursing of the lips, like this. This is pursed lip breathing. And that's it for emphysema. One last revision. So first, definition. So there is permanent damage of acini. Three things: destruction, dilation, and fusion. Etiology. The most common cause for chronic obstructive pulmonary disease is smoking. The specific cause for emphysema is alpha-1 antitrypsin deficiency. Other causes are environmental pollution, genetics, familial reason, and occupation, like pneumoconiosis. Pathogenesis. So it is based on protease antiprotease hypothesis, according to which normally elastase equals to anti-elastase in circulating blood. But if due to any etiological factor elastase becomes more than anti-elastase, there is destruction of elastic fibers and the alveoli loses its ability to recoil, leading to emphysema. And then what does smoking do? Smoking, it increases elastase as well as decreases the activity of alpha-1 antitrypsin. It increases elastase by 10 times, increasing the number of neutrophil. It decreases anti-elastase because the oxidant present in the smoke of the cigarette, it inhibits the activity of alpha-1 antitrypsin. What about genetics? So chromosome number 14 contains the gene responsible for the synthesis of alpha-1 antitrypsin or alpha-1 protease inhibitor. Let's say there is mutation in its gene, like protease inhibitor ZZ, which is disease genotype. There is formation of misfolded alpha-1 antitrypsin, which gets accumulated in the liver, leading to liver cirrhosis, as well as emphysema in lung, liver cirrhosis in liver. Then types, there are 4 types. Centriacinar affects the respiratory bronchiole. Panacinar affects both respiratory bronchiole and alveolar duct and sac. Distal acinar affects alveolar duct and sac. Irregular has irregular involvement. Most common clinically is centriacinar. Most common histologically is is irregular. Smoking causes centriacinar, affects the upper lobe. Alpha-1 antitrypsin deficiency causes panacinar, affects the lower lobe. Then spontaneous pneumothorax is associated with distal acinar. Grossly partial involvement and partial normal is seen in centriacinar. Complete involvement is seen in panacinar. Septal involvement is seen in paraseptal distal acinar. Presence of blebs and bullae are seen in bullous emphysema. Microscopically, 3 terms: destruction leading to floating septa, dilation leading to large acinus, large alveoli, and fusion leading to increased pores of Kohn. Clinically, 2 things: barrel-shaped chest and pink puffer. And we're done with emphysema. Up next, we have chronic bronchitis. So, chronic bronchitis. First, or number 1, definition. Chronic bronchitis has been defined clinically. That is, if a patient comes to you with chronic bronchitis, what type of history is he presented with? This is what you can see in patient. This is the history that you can see in patient. So there is persistent productive coughing. That is, there is cough with mucus. Productive means there is cough with mucus for at least 3 consecutive months, for at least 2 consecutive years. This means, let's say this is 2024 and the patient has had coughing for 3 consecutive months, maybe January, February, and then March. 3 consecutive months. And then again in 2025, he had coughing for another 3 consecutive months, maybe February, March, and then April. So there is coughing, again, productive coughing for 3 consecutive months, in 2 consecutive years. And this is at least. So there is persistent productive coughing for at least 3 consecutive months in at least 2 consecutive years. However, whenever a patient presents to you with a history of coughing, chronic bronchitis does not come in the top hierarchy of your diagnosis. What comes? Something like tuberculosis comes, not chronic bronchitis. That is why you can call a patient, you can tell that a patient has chronic bronchitis only when all other possible suspicions have been ruled out. That is, the person does not have TB, that is, the person does not have any other pathologies that is accompanied with productive coughing. Then finally, if the patient is presented with 3 consecutive months of coughing for 2 consecutive years at least, then that is chronic bronchitis. Alright, one last time. What is chronic bronchitis? Clinically defined, chronic bronchitis is when a person has a persistent productive coughing for at least 3 consecutive months for at least 2 consecutive years when all other possible suspicions have been ruled out. Alright. Number 2, etiology. Again, and I'm repeating again, the most common cause of chronic obstructive pulmonary disease, be it emphysema or chronic bronchitis, is smoking. Other causes are environmental pollution, occupation, genetics, and infection, which is common for both emphysema and chronic bronchitis. Exacerbation. See, a person has chronic bronchitis, but then the condition worsens. This worsening of the condition is called exacerbation. Now, exacerbation can take place 2 ways. Number 1, via infection. And the infection that is most commonly exacerbate chronic bronchitis is Haemophilus influenzae. Second most common is Moraxella. Another exacerbating factor is CFTR dysfunction. When there is dysfunction of CFTR, which is due to smoking, there is mucus production because there is productive coughing, but then the mucus is dehydrated, so the condition worsens even more. Alright, then pathogenesis. See, I mentioned the various etiological factors, right? Where do these etiological factors go and act? It is a bronchitis. There is inflammation of trachea and bronchi. So these etiological factors go and put stress on the wall of the trachea and bronchi. So you have etiological stress on trachea and bronchi, resulting in hyperplasia and hypertrophy of the 2 glands present in the wall of the trachea and bronchi. What are those 2 glands? The goblet cells, the unicellular glands, the goblet cells present in the lining epithelium, right? The ciliated pseudostratified columnar epithelium from the general anatomy, and the submucosal glands present in submucosa. There is hypertrophy and hyperplasia of these glands. As a result, 2 things happen. Due to hyperplasia and hypertrophy of submucosal glands, 2 things happen. Number 1, there is increased mucus production. Obviously, submucosal glands, they contain mucus secreting glands, and they produce more and more mucus. So there is increased production of mucus. Now, what you need to know is that mucus, right? Mucus, it acts as a fertile soil for infection. So since there is lots and lots of production of mucus lining your trachea, bronchi, bronchioles, and even till alveoli, there is infection that take place in respiratory tract, which further exacerbate the condition, that is further worsen the condition. So most commonly, what infection? Haemophilus influenzae. Second most common, Moraxella. Infection can also lead to secondary ciliary dyskinesis. Alright, what if This mucus production is associated with CFTR dysfunction, which is seen due to smoking. Then there is production of mucus, but the mucus is dehydrated. So there is further worsening of the condition, also known as exacerbation. Second thing that happens is there is increase in Reed's index. The normal Reed's index is 0.4. This brings the question, what is Reed's index? So this is Reed's index. See, this is the wall of your bronchus. So there is mucosa. The mucosa contains the epithelial mucosa, lamina propria, muscular layer, and submucosa with the submucosal gland. Reed's index is nothing but A upon B. Now what you need to know what is A and what is B. So A, as you can see right here, is the thickness of the submucosa. No, it's the thickness of the submucosal glands. So this whole thing is submucosa, right? But then this much is the thickness of the submucosal gland. So A tells you the thickness of the submucosal glands. Alright? What is B? B is the thickness of mucosa plus submucosa, the whole thing. Mucosa plus submucosa. Now see, normally the thickness of submucosal gland by thickness of mucosa plus submucosa is 0.4. When there is chronic bronchitis, there is hyperplasia and hypertrophy of the submucosal gland. So there is increase in the thickness of the submucosal gland, but then the overall thickness remains almost the same, right? What I mean is there is increase in numerator, but then the denominator remains almost the same. That means there is increase in Reed's index. Alright, one more time. Reed's index is nothing but the ratio of what to what? The thickness of submucosal glands to the complete thickness of mucosa plus submucosa. When there is chronic bronchitis, there is hyperplasia and hypertrophy of submucosal gland. So there is increase in the thickness of submucosal gland, while the overall thickness remains almost the same. That is, the denominator remains the same, but the numerator it increases. So overall, the Reed's index increases. All right. Gross. So grossly, since there is lots and lots of production of mucus, the small airways, it gets blocked or filled with mucus. Sometimes due to increased production of mucus, lots of fibrosis and inflammation, the lumen gets completely covered up or completely obliterated. The lumen of the bronchiole, this is the lumen of the bronchiole gets completely obliterated, and this is called bronchiolitis obliterans. Bronchio, because bronchiole is affected, itis, because there is inflammation, obliterans, because there is complete covering of the lumen or the obliteration of the lumen. Microscopy, the same thing, hyperplasia and hypertrophy of goblet cells and submucosal glands. Clinical features. See, I said earlier that the alveoli is lined with lots and lots of mucus. That means there is increase in the thickness of respiratory membrane. That means there is decrease in diffusion of gases. Since there is decrease in diffusion of gases, there is decreased oxygen saturation of blood. Since there is decreased oxygen saturation of blood, you have hypoxia. Now, hypoxia can lead to two things. Number one, hypoxemia, reduced oxygen in blood, leading to cyanosis. So the patient is blue. Or see, whenever there is hypoxia, vasodilation of systemic blood vessels take place to supply as much oxygen as possible to the body, but vasoconstriction of pulmonary blood vessels take place. Due to pulmonary vasoconstriction, there is increased total peripheral resistance of pulmonary blood vessel, right? Pulmonary vasoconstriction leading to increased peripheral resistance, vasoconstriction leading to pulmonary hypertension. Pulmonary hypertension, that means the right heart has to work more, it has to press much more harder, it has to work harder, and it ultimately fails to work, leading to right heart failure. Since the right heart has to work harder, the right ventricle has to work harder, there is right ventricular hypertrophy called cor-pulmonale. Since the right heart is unable to pump the blood, there is accumulation of blood leading to peripheral edema, leading to bloating, so bloater. That is why chronic bronchitis patients are often seen as blue bloaters and emphysema patients are seen as pink puffers. Alright, see, here's the thing. Emphysema and chronic bronchitis, both of them are what? Chronic obstructive pulmonary disease. Both of them are strongly associated with what? Smoking. So there are chances that the clinical features of one might overlap with the other. It is just that when there is predominant emphysema, the clinical features of emphysema are more seen. When there is predominant chronic bronchitis, the clinical features of chronic bronchitis are more seen. And in case of emphysema, the typical feature of the patient is pink puffer. And in case of chronic bronchitis, the typical feature of the patient is blue bloater. I'm really sorry for my voice because it's like done for due to all the coughing that I had been going. I didn't have chronic bronchitis again. It was just common cold. All right. So chronic bronchitis, one last revision. Number one, definition. It is defined clinically where there is persistent productive coughing for at least 3 consecutive months, for at least 2 consecutive years, when all other suspicions have been ruled out. Number 2, etiology. For chronic obstructive pulmonary disease, the most common etiology is smoking. Other are environmental pollution, occupation related like pneumoconiosis, infection, and genetics. Then pathogenesis. In pathogenesis, so there is the etiological stress like smoke from smoking, which puts stress on the wall of the trachea and bronchi. As a result, hyperplasia and hypertrophy of 2 glands take place, the goblet cells and the submucosal glands. As a result, there is increased production of mucus. Mucus is a fertile soil for infection. So infection takes place, exacerbation takes place. Infection by Haemophilus influenzae and Moraxella. Sometimes due to smoking, CFTR dysfunction can lead to production of mucus that is dehydrated. This can exacerbate or worsen the condition as well. I'm so sorry for my voice. What is happening? Okay, worsen the condition even more as well. Second thing that happens is that there is increase in Reed's index. Normally Reed's index is 0.4. Reed's index is defined as the ratio of the thickness of submucosal gland to the thickness of mucosa plus submucosa. Since there is hyperplasia and hypertrophy of submucosal gland, there is increase in the thickness of submucosal gland without much increase in the thickness of mucosa plus submucosa. So there is overall increase in Reed's index. Okay, as for gross, you can see that the small tubes, the small airways, they are filled with mucus. Sometimes they are so much filled with mucus, like your bronchiole is so much filled with mucus and fibrosis that it is completely, the lumen of the bronchiole is completely obliterated, which we refer to as bronchiolitis obliterans. Grossly, if you see, this is what you see. Microscopy, if you see, there is increase in Reed's index due to hypertrophy and hyperplasia of submucosa gland. There is also hypertrophy and hyperplasia of goblet cells. And clinical features. Since there is increased production of mucus, the mucus lines the alveoli, increasing the thickness of respiratory membrane, decreasing diffusion of gases, and leading to hypoxia. And now hypoxia, when worsens, can lead to cyanosis. As a result, the patient appear blue. At the same time, due to hypoxia, there is pulmonary vasoconstriction, leading to pulmonary hypertension, leading to right heart failure, leading to cor-pulmonale, leading to peripheral edema. So the patient appears as a bloater. Overall, blue bloater. So, yeah, chronic bronchitis done.